Hi again, this is Tom Mauger for another section on review of optics for your oral boards. The topics in this section are basic soft contact lens fitting, IOL calculations following refractive surgery, and a case of a management of a refractive surgery candidate. As before, I think it's useful to stop the video after each question and think of your own answer before going on to my comments. So the first question is to describe the steps in fitting a spherical soft contact lens. This is a very basic soft contact lens fitting, which is much easier than rigid contact lens fitting, and that will be discussed at another section. So the first step is to pick an initial base curve and diameter. Most soft contact lenses only have a limited number of base curves, maybe one or two, at most three, and probably just one diameter. After the contact lens is on the eye, you need to wait a period of about 10 minutes for the contact lens to settle onto the curvature of the cornea so you can make an estimation of the fitting characteristics, which are basically the centration and the movement of the contact lens with the blink. Having a movement of about 1 millimeter is really key for soft contact lens fitting. More than that, and you get a lot of variability in vision and discomfort. Less than that, the lens is tight and there's no tear exchange, and corneal complications, including punctate keratopathy, can occur. So if the fit shows a movement of greater than 1 millimeter, this can be tightened or lessened by decreasing the base curve, so from going for a base curve of 8.8 to 8.4, or increasing the diameter. So if you have a 13.5 going to a 14 with the same base curve, will tighten the fit. Similarly, if the movement is less than 1 millimeter, increasing the base curve going from 8.4 to 8.8 or decreasing the diameter is helpful. Once the fit is optimized, then over-refract the patient, convert that if appropriate for vertex distance, and then add that over-refraction to the contact lens power in the fitting set to get the contact lens that you should order. So very basic, and anyone who fits contact lenses is cringing right now, but that's the kind of the nuts and bolts of soft contact lens fitting. Rigid contact lenses are similar in that you can alter the movement and the centration by altering the base curve and the diameter. The other issue that base curve impacts fitting is the power of the overall refraction, because in addition to the power of the cornea and the power of the contact lens, there's the power of the tear lens that's formed by the rigid base curve of the contact lens, which does not conform to the curvature of the cornea, unlike a soft contact. So that's what makes rigid gas permeable lenses more complex, is the issue of that tear lens that's created. The next case is a patient who status post-myopic LASIK in both eyes in 2002. They have progressive reduced vision and glare over the past year. They have posterior subcapsular cataracts, worse in the left eye than the right eye. The right eye has a visual acuity of 20/30 and the left eye visual acuity of 20/50 with best correction. Discuss your lens implant calculation and selection process. So again, stop the video here and kind of go through your thought process on this so that you can better see how that differs from my comments. The first question that comes up that you need to ask yourself are, what are the 3 IOL calculation errors that happen post-refractive surgery? And first is instrument error, second is index of refraction error. Those are both involved in the keratometer. And fourth are formula errors, formulas that use the keratometry measurement to determine effective lens position. And this changes, of course, with refractive surgery. So the measurement diameter of our keratometers is a relatively fixed position, although it is somewhat dependent on the curvature of the cornea. The standard Bausch & Lomb type keratometer has a measurement diameter of about 3 millimeters. The IOL Master is quoted as between 2.3 and 2.5, and the LensStar has two annuluses, one at 1.65 and one at 2.3. These are all measured using specific points, so it's not measuring the area of the cornea that's central to that annulus, and it's not measuring the area of the cornea that's peripheral to that annulus. Therefore, a refractive surgery patient who's had myopic treatment will tend to have a flatter cornea in the center than what the keratometry normally measures. And similarly, a hyperopic PRK or LASIK patient will have a steeper cornea in the center than peripherally because of the overall transition zone. So the instrument itself is not designed to measure the cornea. Now, more modern topographers are getting better and better at measuring the very center of the cornea, and those can be very helpful in these patients, as we'll discuss later. The second error is the index of refraction error, and I would urge you to look up this paper by Guttmark and David Guyton on Survey of Ophthalmology in 2010 about the history and origins of the keratometer. It's really helpful to kind of see where this information got to us. As you know, the keratometer is a instrument that measures the reflection off of the cornea, actually the tear film that's on the cornea to be specific, and we'll be able to determine the curvature of that surface using that reflection. So the base curve that can be determined from that is what's useful. The problem is in determining the refractive power of the cornea, which is what you really need in order to be able to do IOL calculations. In order to effectively do this, you need to assume a refractive index of the cornea and also take into account the posterior surface of the cornea, which is a negatively powered surface, since it goes from the higher index of refraction of the cornea to the aqueous. The power of the posterior surface, though, is much less because the difference in the index of refraction is much less than the anterior surface. Going from air to the cornea has a much larger difference than from the cornea to the aqueous. The power of the posterior surface varies somewhere between -5 to -7 diopters and is related to the power of the anterior surface of the cornea. So if the anterior surface is steep and high powered, the posterior surface is also steep and high powered in most cases. So the compromise to try to get this power of the cornea as close as possible was to use a compensated index of refraction in the calculation. So the true index of refraction of the cornea is 1.376. The compensated index that would take into account the negative power of the posterior cornea is 1.3375. In the paper you'll see people have come up with different numbers for that, but they're all very close to this number. And that is taking into account that the relationship between the anterior and posterior cornea is always there. When you flatten the cornea with a myopic LASIK, that relationship no longer exists, and therefore the compensated index of refraction is no longer accurate. So that correspondence between the anterior and posterior surface of the cornea is nothing you can depend on after refractive surgery is performed. Radial keratotomy would theoretically cause both the anterior and posterior surfaces of the cornea to bend similarly and would be more accurate, although the annulus and measurement zones of the instruments are even more inaccurate with radiokeratotomy in most cases, since they're so irregular. So, and we already discussed the problem with the formulas that take and use the keratometry measurement to calculate out the effective lens position. Formulas like the SRKT formula use the keratometry measurement in making this calculation. Other formulas actually directly measure the anterior chamber depth with the IOL master and use that in their calculation. So you need to know which of your formulas actually will use the keratometry measurement, and we'll discuss that in a minute, how you can make an adjustment for those if you do want to use those formulas. So the calculation methods for post-refractive surgery lens implant calculations include the clinical history, which is the one that's most commonly asked about and known, the rigid gas permeable contact lens fitting method, which is not used practically, topography indices, which can be helpful and are getting more helpful all the time, and then special formulas, which I won't go into great depth on, but they're out there. I think the most notable one is the Haigis-L formula, which makes an adjustment in the keratometry according to an algorithm that Dr. Haigis has published, and is reasonably accurate when you don't have any clinical history. But first, the clinical history method, I think, is probably the one you'll get asked about the most. And in this example, the pre-LASIK average keratometry measurement was 43.5, and this is a measurement you can really rely on because it's a virgin cornea, and you can assume that it is accurate. The pre-LASIK spherical equivalent refraction was minus 6.00 diopters. That needs to be converted to the corneal plane, assuming the vertex distance. The post-LASIK spherical equivalent in this case is plano. And then the post-LASIK average keratometry measurement is 40.5. Remember, the patient's now status post-refractive surgery, so for all the reasons that we talked about, the instrument error and the index of refraction error, that measurement is not one you can rely on. So that measurement you'll see, but you should just kind of discount that as a reliable and useful method. So in making your calculation, you will use your pre-op K because that's a reliable measurement, and you'll look at the refractive change and assume that 6 diopters has been converted by vertex distance back to the plane of the cornea. And if the patient has had a 6 diopter reduction in myopia, then that had to happen at the cornea because that's the only part of the eye that was changed. So that 43.5 diopter cornea now has become an effective 37.5 diopter cornea, and you can use that in your IOL calculations. Note that the post-LASIK keratometry measurement is not used in the clinical history method. You may be given that, but you don't want to use that. So if you use this 37.5 in the formulas, you have to be careful which formula you use. As we mentioned, the example that is given in this paper is the SRKT formula that uses keratometry in their calculation of effective lens position. So if you use the calculated keratometry measurement, the 37.5 in this, it will assume an effective lens position that's relatively shallow, as you would expect to see if a natural cornea was flat. You would assume that the patient would also have a fairly shallow anterior chamber depth. This is, of course, not the case. The patient's actually highly myopic, and the anterior chamber depth is consistent with that. So in this formula, you would use the pre-treatment keratometry measurement for the part of the formula that calculates the effective lens position. And this paper describes how to do that. I recommend that you would look through that if you're interested. Thank goodness that our societies have helped us out with this. Ascaris in particular has been very generous in developing a calculation tool that's freely available on their website, even if you're not a member of the Academy. Dr. Hill, Dr. Wang, and Dr. Koch update this frequently based on the evidence that's in the literature. And they have spreadsheets for prior myopic LASIK and PRK, for hyperopic, and also for RK. And they essentially include all of the formulas that are available, that are published and seem to be valid for calculating these. And this includes the clinical history method. This includes the topography methods that are constantly being changed for calculating true corneal power, especially with the Scheimpflug devices such as the Galilei and the Pentacams. And then it puts it into a spreadsheet along with some of the special formulas such as the Hague-Cell, so that you get a range of different powers, and you can then select which power that you want to use for the patient. It's important to realize that the patient will have an increased risk of having the power not be correct after surgery, and that the patient needs to be informed about this. In my experience, the patients that are most likely to have problems are the patients with very aggressive radiokeratotomy surgery in the past, who have not only a very irregular cornea and a very small optical zone that's difficult to measure, but also have diurnal fluctuations in their refraction and their keratometry that worsen after cataract surgery, at least initially. So those patients, I think, are the ones that probably should be treated especially delicately in the discussion. Finally, the rigid contact lens fitting technique is not one that really is used practically for post-refractive patients. I've used it in the past for patients with otherwise scarred corneas to try and get a power that was close to what their effective corneal power is. The steps to doing it are to perform keratometry on the eye as best possible, perform the manifest refraction in the eye, and then place a known power rigid contact lens with a base curve that's similar to that keratometry measurement. It's best to use a plano contact lens power. It makes the calculations easier. Once this is placed on the eye, then the eye is over-refracted, and that is converted for vertex distance if needed. The amount that the over-refraction is different from the combination of the manifest refraction and the contact lens power is due to the power of the tear lens that's created by the space or difference between the base curve of the rigid contact lens and the effective curvature of the cornea. So for example, let's say a patient has a corneal power of 42.12, which has a base curve of 8.0. Their status post radiokeratotomy. Cornea measures as I described. The refraction is plus 2.00 spherical equivalent, which is very common for a patient who's had radiokeratotomy and consecutive hyperopia. You choose a rigid contact lens with a 0 power and a base curve of 8.02 used as a trial lens. And then the over-refraction is plus 0.50. So the difference between the spherical equivalent of the patient's refraction combined with the power of the contact, which is in this case 0, and the over-refraction is 1.5. And that difference in power must be occurring at the tear lens, the space between the base curve of the contact lens and the curvature of the cornea. So the cornea really is not a power of 42.12. If it was at 42.12, the over-refraction would have been plus 2.00. But because the over-refraction was plus 0.50, the effective power of the patient's cornea is less than 42.12, and in fact is 40.62. So again, the center of the cornea that the patient uses after radiokeratotomy or myopic LASIK is usually flatter than what you would measure with your devices. So again, this is not something you would use practically. It's not especially accurate, but it can be helpful for scarred corneas. This whole concept of post-refractive surgery calculations for lens implant calculations is constantly changing, and I would urge you to update yourself frequently on this, and especially when considering using premium lens implants such as toric and multifocal or accommodative lens implants, because accuracy in the refraction is really critical, and doing further keratofractive procedures in an eye that's already had one is increasingly risky, and would be something I would try to avoid at all costs. The last question of this section is concerning a second opinion for a LASIK evaluation. The patient is 40 years old. Refraction is in the right eye minus 0.50 and in the left eye minus 3.00. The patient sees 20/20 in each eye with correction. He is a truck driver and would like to use both eyes for distance, and claims not to mind wearing reading glasses, but just wants to be able to see with both eyes, especially for night driving. And the questions are, how would you evaluate this patient, and what would your advice be for this patient? So stop the video and kind of write down the things that you would normally look at for refractive surgery evaluation. So it's important, of course, to take an accurate history to look for any kind of contraindications for refractive surgery, such as rheumatoid disease, previous history of eye infections, herpes, patient's male, so pregnancy is not an issue. Diabetes might impact healing. The patient's exam includes keratometry, topography, looking for any kind of ectasia. Pachymetry should be performed, looking for thin corneas. Pupillary diameter should be measured in the light and in the dark to make sure the patient's not at high risk for glare or halos, and this will be particularly important for this truck driver who might be driving at night and may be on the same highway as you. The patient's slit lamp examination and retinal examination need to be performed. Typically at this point, if everything that has been worked out, including tear film evaluation and lid position, blepharitis is negative, the physician will then okay the patient to have LASIK in the left eye to correct that eye for distance, and most probably leave the right eye alone. And they have not asked for one piece of history that's important. I would say 10% of candidates who've looked at this question miss this aspect. One aspect of the history that really needs to be determined is the past refractive history. And this can be done several ways. One is by getting their old records. Hopefully this can be obtained from their optometrist or even their optical shop to confirm that the refraction has been stable for at least 6 to 12 months. The patient's history can be helpful, although is somewhat unreliable, and that should not be used as confirmatory without true records. So in this patient, they were able to find old records, and 6 months prior to this visit, the right eye was minus 0.50 and the left eye was minus 2.00, and 12 months prior to this, the patient was plano in the right eye and minus 0.50 in the left eye. So obviously the patient's becoming more myopic in the left eye. The keratometry and topography in the left eye and the right eye are the same. and one would assume that that has not changed. And when you look closely at the patient again with this information, you'll see they do have some nuclear sclerosis and have had a myopic shift due to nuclear sclerosis and early cataract. And that sounds like something you probably wouldn't miss in a patient or a candidate, but this is an actual patient that I saw for consultation. The only difference is that the patient had already had LASIK in the left eye 1 year prior to their visit with me. And when I got the records, they were -3 in the left eye at that time and had LASIK and were plano immediately after surgery. But by the time they came in to see me, they were -3 again in that eye and had a myopic shift further with the increasing nuclear sclerosis in that eye. So my job is to tell the patient not only could they not have a touch up on their LASIK, that they were probably going to need cataract surgery in the future, and further, they were now post-refractive surgery candidate, and that would complicate the IOL calculations. So it's important to make sure someone's refraction is stable prior to doing refractive surgery. And similarly, that is the case with premium lens implants with patients that have unstable cornea, say with keratoconus or after keratoplasty. It's a relative contraindication. That doesn't mean you could not do it, and there are a number of studies that show good results, at least in the short term, with toric lenses in patients with stable, supposedly keratoconus or stable corneal curvature after cornea transplant. My only concern is that if those patients go on to need another keratoplasty in the future, or if the keratoconus isn't as stable as you might think, and they need rigid contact lens fit, that will reveal the astigmatism correction in the toric lens implant and then require the patient to have glasses over correction, which is very difficult to manage. We'll have another question about toric lens implant usage in the future. So that's it for now. Thank you again for your attention. Good luck in your optics studies.